Okay, so today we're going to be going over hypertension, which is definitely an important topic. There's not a whole lot to know with this. It's not really a difficult topic, but there's definitely some things that you need to know for the PANCE and for your exam. So we'll go over everything that's included on the NCCPA blueprint. So that's going to be essential and secondary hypertension, hypertensive emergencies, and hypertensive urgency. So really quickly, I always want to thank you guys for the comments, the likes. It really is amazing, and it definitely makes my day every single time I see one of those comments. So thank you so much for that. Let's go ahead and get started with hypertension. I'm sure we all pretty much know what hypertension is. Obviously, it's an elevation in blood pressure over a specific target that we'll go over later on. But there's a couple different types of hypertension. So there's two etiologies that you need to know of. The first is going to be primary or essential. Now, primary or essential is the most common type. It's the one you're going to see every day in the office when you're seeing patients. About 95% of the causes of hypertension is going to be primary or essential. It's generally idiopathic, so we normally don't know exactly what's causing it. But with that being said, there's actually a bunch of different risk factors which you're probably pretty familiar with. None of these will probably be anything new that to you as far as risk factors, but let's go over them real quickly so you at least hear them, and I'm sure a lot of them they'll be just be repeating things you already know. So obviously advancing age is a risk factor for hypertension. As you get older, vessels become stiffened, calcified, and the blood pressure goes up. Obesity is another big one. Family history of it's actually twice as common in patients with hypertensive parents. So family history is a big one for hypertension. Race, in particular African Americans, are more predisposed to hypertension. High sodium diet, over 3 grams daily. Excessive alcohol intake and physical inactivity are all risk factors for primary or essential hypertension. Now, there's another etiology for hypertension, and this one is secondary. So secondary is not very common. It only makes about 5% of all the cases of hypertension. So you're not going to see it very often. It doesn't mean you won't be tested on it. It just means in real life you may never come across a case of secondary hypertension, but they're definitely going to ask you a question on the boards about it. So normally, compared to essential or primary hypertension, which normally is idiopathic, we don't know the cause. Secondary hypertension, there normally is an underlying identifiable cause that we can actually specifically target and treat to remedy the hypertension that we see. Now, the one that you absolutely have to know, and it's the most common cause of secondary hypertension, is going to be renal vascular causes, in particular renal artery stenosis. That's the one you'll most likely see in a question on a vignette, so really know that one. That's the most common cause, and it's the one they'll likely ask you about. Now, there's some other ones you should be familiar with as well. Coarctation of the aorta. In particular, if you have a younger child or just a younger patient that has hypertension, you should be thinking coarctation of the aorta being a possible or being in your differential. Cushing's syndrome, pheochromocytoma is another cause. Medications, oral contraceptives, especially the ones with the higher estrogen levels, chronic NSAID use, and then decongestants that contain pseudoephedrine. All those medications can cause a secondary hypertension. Sleep apnea is another common one as well. So be familiar with these, but definitely concrete that renal artery stenosis in your head, because that's probably going to be the one that you're going to be asked. And if you ever do see a secondary cause of hypertension, that's your most common cause. So that may be the one that you actually see in real life. Now, as far as diagnosing hypertension, you're going to go by some specific guidelines or criteria. There's a few, but the most common one, the one that you'll see really in clinicals and on the exam, is going to be the 2017 ACC AHA guidelines, which is the American College of Cardiology and American Heart Association. So this is the one that you need to know. This is the one that most physicians and healthcare providers go by. So the actual guidelines for this, let's go over it. A normal blood pressure, according to the 2017 ACC-AHA guidelines, is going to be less than 120 systolic and less than 80 diastolic. So that's going to be a normal blood pressure. As soon as you hit 120 to 129 systolic, still less than 80 diastolic, but as soon as your systolic goes anywhere from 120 to 129, it becomes elevated. Honestly, that's not important. It really means nothing. That's not hypertension. It's just elevated, which means nothing as far as treatment, as far as a question. They're not going to ask you that. So these are, I'm going to go over these, but this is the one you really need to know. Of all of these, this is the one. If you're going to remember one of these, remember this one. So stage 1 hypertension, as soon as they hit 130 to 139 systolic, and or can be either one of these or both. 80 to 89 diastolic, they're hypertensive. Stage 1 hypertension, but they're hypertensive. And at this point, you have to have some form of intervention. So that's the one you really need to know. If you forget all the other ones, just remember that. Because as soon as you hit that point, you're hypertensive. Now, stage 2 hypertension is anywhere over 140 systolic and or over 90 diastolic. But again, remember, as soon as you hit 130 systolic or as soon as you hit 80 diastolic, you've become hypertensive as soon as you hit those guideline numbers. So remember that. That's the one you really need to know. But these are all of the guidelines for the 2017 guidelines. So those are the ones that you should be familiar with. Now, it's important to note that you can't have a patient come in, you take their blood pressure, it's 150 over 90 and say, okay, you have hypertension, here's your medication, or here's your lifestyle changes we're going to implement. It doesn't work that way. You actually need two separate readings on two separate visits at the defined hypertensive level. So you actually need a couple different readings on two separate visits to make the diagnosis. So you don't just make it one time. Even if you check their blood sugar 8 times that same day on that same visit, you still don't make the diagnosis. It has to be two separate visits, two separate readings to actually make the diagnosis of hypertension. So that's the guidelines you should know. Really, again, focus mainly just on the stage 1 hypertension, because as soon as you hit that, they've become hypertensive, entered into that realm, and you need to start to have some form of intervention. Okay. So complications. There's some complications. Obviously, we know with hypertension, the reason you want to prevent hypertension is because there are complications. Now, the ones you should really focus on are going to be your cardiovascular and your renal. So those are the ones that are going to be most common, and those are going to be the ones that are really damaging to patients that we want to prevent. So cardiovascular, some of the things that you'll see, some complications: left ventricular hypertrophy, heart failure, ischemic heart disease, MIs are all things that can come from long-standing hypertension. So definitely know those. Renal causes, you're going to see some renal complications, chronic kidney disease, end-stage renal disease. And just as a side note, as far as the complications with cardiovascular and renal, with cardiovascular, the hypertension is actually the most prevalent modifiable risk factor for premature cardiovascular disease. It's even more prevalent than diabetes, smoking, dyslipidemia. So it's really important to treat hypertension when we do see it in our patient population. And in chronic kidney disease, hypertension is actually the second most common cause of end-stage renal disease in the U.S., second only to diabetes. So it very commonly can cause all of these problems, and it's really something that needs to be treated when it is identified. So just, a little side note for you to be aware of. And then, of course, there's neurologic complications, CVA, TIA, retinopathy. That's why we always do our fundoscopic exam to check for that. So some other ones you should be familiar with, but really focus on that cardiovascular and the renal causes, because those are very important. Now, once you make the diagnosis of hypertension, these patients are going to need a workup. You don't just give them their ACE inhibitor, their calcium channel blocker, and send them on their way, tell them to lose some weight. You actually need to do a workup, because as soon as you diagnose hypertension, you don't know how long they've had it. You don't know what complications they may have developed, and you still don't know if it's a secondary cause. So the workup you're going to go through with these newly diagnosed hypertensive patients is as follows. So you want to get a fasting blood glucose. You want to make sure they're not diabetic, urinalysis, and a urine to albumin creatinine ratio. And what that is used for is to check for proteinuria, which is an early indicator of kidney disease. So you want to check for that because, like I said before, renal can be one of the complications you see in kidney disease. So you want to check for that. CBC, TSH, you want to check the potentially may have some hyperthyroidism that maybe is causing the hypertension. Lipid profile, you want to make sure they don't have coexisting hyperlipidemia. ECG, of course, we're checking for left ventricular hypertrophy or any other potential changes, any heart failure or anything like that. Electrolytes, serum creatinine. Again, your creatinine is another way to check kidney function, make sure there's no degradation in the kidneys from long-standing hypertension. You want to calculate their 10-year atherosclerotic CVD risk to see how high of a risk they are and how aggressive you need to be in your treatment. And then finally, a fundoscopic exam. You're looking for retinopathy. Again, hypertension affects all of the vessels in the body, so you can have some signs of retinopathy in the small vessels of the eye. So that's the workup you want to do with your newly diagnosed hypertensive patients. This isn't necessarily extremely important for the boards. They most likely won't ask you a question on this, but you should be familiar because you're going to be practicing medicine one day and you want to know the things that you need to do with your patients, especially if you're in primary care. Now, Treatment, this is going to be probably the most important part that we're going to go over. So treatment initially, when you have a patient, you should implement some form of non-pharmacologic therapy, so aka your lifestyle changes. So this can be done initially to see if these patients can maybe lose some weight, get their blood pressure down to a normal level, or it can be used in addition to pharmacologic therapy if you're going straight to medications if their blood pressure is extremely high. So let's go over some of the different lifestyle changes you'll initially make. Obviously, weight loss is a big one. And actually, for every 2 pounds a patient loses, generally the blood pressure will decline anywhere from 0.5 millimeters of mercury to 2 millimeters of mercury. And that's coming straight from UpToDate. So that's like, pretty impressive. And it's actually from studies that they've shown. So it's you can have a pretty significant decrease in your blood pressure with just weight loss alone. Now, the diet you're going to want to know or be familiar with is the DASH diet, which stands for Dietary Approaches to Stop Hypertension. It's a pretty common sense diet. I'll show you a picture here of the things that they want you to eat and what they don't want you to eat. It's honestly common sense, but you just want to be somewhat familiar with it because they may ask you what type of diet should these patients be on. And basically, the DASH diet is just a diet that's high in veggies, fruits, whole grains, lean proteins, and low in red meat, sugars, refined carbs, and things like that. So just be somewhat familiar with the DASH diet in case they do ask what type of dietary changes you want them to make. Exercise, of course, is extremely important. You want to limit your alcohol intake. Smoking cessation, of course, is important as well. As far as the amount of alcohol you should be telling your patients that they can have, in men, generally, it's 2 or less drinks a day, and in women, it's normally 1 or less drinks in a day. So that's normally the limits you want to advise your patients, or no alcohol at all, to be honest. But dietary salt restriction is another important one I'm sure we're all familiar with. And then the last one may be one that you may not be that familiar with. Most of these are pretty common sense, but potassium supplementation is really important initially for these patients. And a patient with low dietary intake of potassium has actually been found to have much higher blood pressure than a patient that takes potassium supplements, and patients with normal potassium levels that take potassium supplements, normally from foods, normally gathering it from foods, not necessarily medication, but these patients have actually been found to have lower blood pressure. So for any reason there is, these patients are low in their potassium intake, you want to make sure they take either potassium supplements or make sure they're eating the right foods to get that from. So that's one that you may not have been familiar with, that you should know, that could potentially be asked. Okay, so lifestyle changes are important, but really most of the time when you're asked a question on the exams, it's going to be about the medications because that's the easiest to test you on. So let's go over the pharmacologic therapy. I'm just going to make a quick note here that I'm going to be making a separate video, YouTube video, going over all of the hypertensive medications, the classes, really diving deep into all the pharm about the meds, the ADRs, the contraindications, and all of that. I'm going to go over the meds you need to know and who you're going to use them for and things like that. Enough to answer the questions on the boards, but the other video I'll go deeper into the actual medication so you can be more familiar with those because that's important as well, and I think it deserves its own video. Okay, so with that being said, as far as pharmacologic therapy, if a person does not have a compelling indication for a specific drug or class, they're not diabetic, they're a non-African American patient, and I'll go over that in a minute, the medications you use for those types of people. So uncomplicated non-African American patient, you're going to choose any one of these 4 classes, and there's no wrong answer. You can choose any one of these. So it's going to be either ACE inhibitors, that's going to be your prils, your lisinopril, captopril, etc. Your ARBs, that's your angiotensin II receptor blockers, that's going to be all your sartans, your losartan, candesartan, all of those. Thiazide type diuretics like hydrochlorothiazide. And then finally, calcium channel blockers. For calcium channel blockers, most often you're going to choose a dihydropyridine, like amlodipine is one of the more commonly used. So you have a patient, uncomplicated, they're not diabetic, they don't have any chronic kidney disease, they're a non-African American patient. You can choose any one of these 4 classes, and they're all right. So it's ACE inhibitors, ARBs, thiazide type diuretics, or calcium channel blockers. Any one of those. Really know that. That's important because that's going to get you your answer to the question. Now let's go over the complicated patients, the African American patients, so we can understand the medications you'll use with those patients. Now, if a patient has a history of diabetes or chronic kidney disease, 100% you are going to use an ACE or an ARB. That's really important in these patients. You need to know that if they're diabetic, especially if they're diabetic, or they have a history of chronic kidney disease, you're going to use an ACE or an ARB. And that's because ACEs and ARBs actually slow the progression of nephropathy due to the effect of on the efferent arterioles, causes vasodilation. I'm not going to get into the MOA, but basically any patient with that's at risk for chronic kidney disease, like diabetics obviously, or that have chronic kidney disease, ACE or an ARB, 100%, that's what you want to use in these patients. It's really important. And actually, diabetic patients, even in the absence of hypertension, will still be put on an ACE or an ARB because of how well these medications reduce the rate of chronic kidney disease in these patients. So it's important for you to know that for the boards and for real life. Now, if you have an African American patient, you're going to stick to either calcium channel blockers or thiazides. Now, the reason is because studies have shown that in African American patients, there's actually decreased efficacy in drug classes such as the ACEs or the ARBs, and they actually respond better to calcium channel blockers than thiazides. So remember that African American patient, you're going to stick to calcium channel blockers, thiazides, stay away from the ACEs and the ARBs. So that's important as well. And you may have noticed that I didn't mention beta blockers. So beta blockers do have their place, but generally beta blockers are not going to be used as first-line monotherapy unless these patients have a history of ischemic heart disease or heart failure with decreased ejection fraction. So you're only going to use beta blockers if a patient has a history of ischemic heart disease or heart failure with decreased ejection fraction. So remember that. I didn't actually write beta blocker there, but that's what that sentence is. That's what that sentence is supposed to say. So beta blockers only in a patient with a history of ischemic heart disease or heart failure with decreased EF. You're never going to use it otherwise. You're never going to just start a patient on metoprolol or something like that. It's just not used. They don't work well enough in your general hypertensive patient. Only if they have that specific history will you use a beta blocker. So remember that. Okay, so, oh, and there we go. I'm sorry, I listed it down at the bottom there. I didn't realize that. So beta blockers, tenolol, carvedilol, only going to use in those specific situations. Otherwise, they'll never be used as first-line monotherapy. All right, so moving on. A little side note that I wanted to mention as far as the treatment options and different things like that. If you have a patient, you're using, you started them on an ACE, an ARB, a calcium channel blocker, etc., whatever you used, and they're not getting to goal. Generally, there's a few different goals, some more aggressive than others, but generally less than 140 over 90 is what you'll be shooting for. If they don't get to goal with monotherapy, you're going to add a second drug from a different class. Now you may wonder, okay, they're on lisinopril, why don't I just give them a higher dose of lisinopril? Well, it actually turns out that starting them on a second drug from a different class is actually more effective at lowering the blood pressure than just doubling the dose. And in addition, it actually normally has a lower side effect profile. So instead of just doubling the dose of the med that they're already on, it's more efficacious to add a second drug from a different class, and you'll actually see less side effects. So if for some reason you get a question, the patient's not at goal with one, with the lisinopril, and they say, well, you're going to double the dose, or you're going to add another class, you're going to add another class. That's the right answer for that. And then another side note, and this is really important because I definitely had questions like this in school. I remember one specifically. If you have a patient that's refractory to multiple different hypertensive medication classes, you need to be thinking secondary hypertension. And I remember the question in school, it was a patient that was on 3 or 4 different classes of antihypertensive medications. They weren't getting to goal. What's the next test you should order? And it was actually a renal ultrasound, because you needed to realize this patient likely had secondary hypertension, and you needed to do that renal ultrasound to rule out the most common cause of secondary hypertension, which was that renal artery stenosis or some other renal vascular cause. So remember that. That's really important, and that could be a question. So those are just some side notes. These are the things that I really feel like you need to know. If you're going to take away 5 points from this, you forget everything else, remember these, and you should be okay. So uncomplicated hypertensive patient, non-African American, you're going to use your 4 classes. Remember that: ACEs, ARBs, calcium channel blockers, thiazides. Systolic blood pressure of 130 or higher, or diastolic of 80 or higher. 2 separate readings, 2 separate occasions is by definition hypertension. That's really the numbers you need to remember. Most common cause of secondary hypertension is a renal vascular cause like renal artery stenosis. Medication of choice in a patient with a history of diabetes or chronic kidney disease is an ACE or an ARB. And then the medication of choice for an African American patient is a calcium channel blocker or a thiazide. So really important that you remember this slide here. Those are your need to knows. Those are your 5 takeaway points I think you really need to remember. Okay, so let's move on to the last topic for hypertension that the NCCPA blueprint wants you to know, and that's going to be hypertensive emergency and urgency. So these are two different topics, but there's not much to know. There's not a lot different about them either. So the only difference between the two, hypertensive urgency is going to be a systolic blood pressure over 180 and or a diastolic BP over 120 with no evidence of end organ damage. Now, hypertensive emergency is the same exact thing, over 180 and or over 120, but you now have an evidence of end organ damage. So you may be thinking, what is end organ damage? What does it look like? How does it present? So these are signs of end organ damage. And all end organ damage is that these patients have had really high blood pressure, most likely for a while, and they're starting to have some serious complications. Their organs are just getting messed up because of how high the blood pressure is and how long it's been going on for. So some signs of end organ damage: chest pain, back pain. These patients may have an MI, an aortic dissection. They may be having those symptoms. Dyspnea, may have some congestive heart failure, pulmonary edema due to the hypertension. Altered mental status, they may be having an ischemic or hemorrhagic stroke. Seizures, I put headache in red because that's actually going to be your most common clinical manifestation in hypertensive emergency or urgency. Headache by far is going to be the most common presentation for that. So remember headache. So those are the signs of end organ damage. So if you see end organ damage combined with a BP, systolic over 180 and or diastolic over 120, you should be thinking hypertensive emergency. You see the same BP but no evidence of end organ damage, they come in, they're fine, then it's going to be urgency, obviously not as serious. Okay, so let's go over the treatment in urgency. So it's similar to emergency, but it's not, as we went over before, you don't have any end organ damage, so you're not going to be moving as fast here. You're going to use different agents. So you want to reduce the mean arterial blood pressure. And if you don't remember what mean arterial pressure is, it's the average arterial pressure during a single cardiac cycle. So you want to decrease it by no more than 25% over 24 to 48 hours using oral antihypertensive agents. Now, in emergency, you're going to be using IV antihypertensive agents, and you want to reduce the mean arterial pressure by approximately 10 to 20% in the first hour and by 5 to 15% over the next 23 hours. Now, you may be thinking these patients have an MI, these patients are having all these things going on in the body. Why are we waiting so long and why are we working so slow at decreasing the blood pressure? We can decrease a blood pressure with IV agents in less than a half an hour to normal levels if we wanted to. Why would we wait almost 24 hours? So the reason is these patients normally have long-standing hypertension. They've had it maybe for years, months, however long. Their organs have actually become accustomed to living in this hypertensive environment, if you want to picture that. So the higher blood pressure in these organs, they've actually the vascular beds of these organs have actually almost adjusted to this high blood pressure, and they've become accustomed to that. So if you dramatically decrease the blood pressure really fast, they may actually shut down. You'll have this ischemia, and you're going to have potentially damage to these organs. So as soon as you just completely shut down the blood pressure, drop it really quickly, you have ischemia and damage to these organs. So you don't want to do it too fast. You don't want to shock the organs. So the general rule in emergency, that's the one you really need to know, is going to be to decrease the mean arterial pressure by 10 to 20% in the first hour and by 5 to 15% over the next 23 hours. Now, there are some exceptions to this rule, so remember that, but remember there's 3 exceptions that you need to know. So the 3 exceptions, and they're going to make a lot of sense when I go over them. So in emergency, hypertensive emergency, there's 3 exceptions that you need to be familiar with that won't follow this rule of 10 to 20 in the first hour and then 5 to 15 over the next 23. The 3 exceptions are going to be ischemic stroke. And if you think about it, it makes sense. So in ischemic stroke, you have this patient that has this area of ischemia. The blood is not perfusing to the brain. It's not getting through this area. So you actually want to keep that blood pressure pretty high. You're not concerned about decreasing it. And in a patient with ischemic stroke, if you are not going to use thrombolytic therapy, you're not going to do reperfusion therapy like TPA or clot busters. You have a patient with stroke, you're not going to use that. Maybe there's a contraindication. You can actually let them ride with a BP as high as 220 over 110. You can leave it at that, and it's actually beneficial to the patient because that high pressure, think about it. If you have like a clog in a hose, and you turn the pressure down, that water's not going to get through. But if you crank that pressure really high on the hose, it may just kind of like push through that narrowed area of the hose and get through. So you actually want to keep the pressure pretty high in an ischemic stroke. If for some reason you do give reperfusion therapy, you're going to give them TPA, you kind of max out the BP at about 185 to 110 before you start to treat. So that's one exception. The other two are kind of for the same reason. So you have a patient with acute aortic dissection. They have a dissected aorta. There's blood spraying out through this dissection. You can't wait 24 hours to decrease this patient's blood pressure. They're going to die. If you waited 24 hours, they wouldn't be there anymore, likely, in an acute aortic dissection. So these patients, you actually have to rapidly decrease the blood pressure, and the target normally is going to be to about 100 and 120 in about 20 minutes. So you can't wait. You can't think about, oh, well, maybe this organ will have ischemia. They're going to die, so you don't have that option. And then for the same reason, if a patient has an intracerebral hemorrhage, you're not going to be following that same protocol over 24 hours. You're obviously going to be following a much faster protocol to decrease the blood pressure. So those are your exceptions. Those are the three things you need to remember. If they don't mention any three of those, you know that you're going to follow that formula 10 to 20% first hour, and then 5 to 15% over the next 23 hours using those IV antihypertensive agents. Now I'm going to briefly go over the IV agents that are used, but don't waste too much time like memorizing all the different meds and this does this, and they're not generally going to ask you much about the specific different meds. You just need to be familiar with some of the ones that they use so you can pick it out on vignette and get it right in the answer. So I'll briefly go over the different medications that are used. So the ones you'll commonly see used because of the half-life and things like that are going to be nitroprusside, nicardipine, labetalol, esmolol, and clofidipine. So these are all IV agents, antihypertensive IV agents. Now there's a couple that you should be familiar. The nicardipine and the clofidipine are generally used in patients with neurologic hypertensive emergencies, and then esmolol and labetalol, the beta blockers, are generally used in cardiovascular hypertensive emergencies, a lot of times in a dissection and things like that, because they decrease, it's called shearing forces, so you use those generally, the beta blockers. So again, don't waste too much time on memorizing those meds, but just be somewhat familiar with some of those that I went over. Now, let's go to your need to know. There's only really three things that I feel like you really have to know. So know the difference between urgency and emergency. So you want to know that it's a BP over 180 systolic and or over 120 diastolic, but only emergency has those signs of end organ damage. Know the formula or know the rate of decreasing the blood pressure in an emergency if there isn't any of those exceptions I went over. So otherwise, make sure you remember you're going to use IV antihypertensives, decrease 10 to 20% in the first hour, another 5 to 15 over the next 23 hours, and then the three exceptions are going to be an ischemic stroke, intracerebral hemorrhage, and aortic dissection. So those are the things that I feel like you need to know. There's not too much with emergency and urgency. All right, so let's wrap it up. We'll test your knowledge. We'll do 5 quick questions, and then we will be done. Let's see what you can remember here. So in an uncomplicated, non-African American patient, which are the 4 drug classes you will choose from for initial monotherapy? What are the 4 drug classes, non-complicated, they don't have diabetes, they don't have chronic kidney disease, and they're non-African American? What are the 4 classes? So ACEs, ARBs, calcium channel blockers, and thiazide type diuretics. Know that very well. What is the most common cause of secondary hypertension? Most common cause of secondary hypertension is going to be renal vascular cause, renal artery stenosis specifically. You should know that very well as well. At what blood pressure reading is stage 1 hypertension defined? What blood pressure reading? Stage 1 hypertension. That is going to be 130 to 139 systolic and or a diastolic of 80 to 89. That's the one you should really remember. If you forget all the other ones, that's the important one. What are the two medication classes that should be used in a patient with a history of diabetes or chronic kidney disease? So diabetes, chronic kidney disease, the two medication classes, you want to choose either one of these. It's either going to be an ACE or an ARB you want to use in those patients. And finally, in a patient with a hypertensive emergency, describe the rate of reduction for BP over 24 hours. Of course, no history of ischemic stroke, dissection, etc. The rate of reduction is going to be decrease the mean arterial pressure by 10 to 20% in the first hour, and then an additional 5 to 15% over the next 23 hours. Okay, hopefully you got all of those right. Thank you so much for watching the video. I hope this has been helpful, and as always, good luck on your PANCE, your PANRE, your EORs, and good luck in PA school.